This videotape illustrates our approach to the treatment of the Chiari 1 malformation. The patient being treated is a 51-year-old woman with a 7-month history of headache, ataxia, hoarseness, and difficulty swallowing liquids, and a 6-week history of numbness in the left side of the face and left upper extremity. Patient is positioned in the 3-pin Mayfield head holder. Patient's positioned on soft chest rolls. The neck is flexed slightly. The incision extends 5 centimeters superior to the inion and 2 centimeters inferior to the spinous process of C2. On the T2 weighted MRI study of the cervical spine, you can see a Chiari 1 malformation and a central syrinx at the C2-3 level. The midline incision provides space for a triangular graft superior to the inion that is being taken here, and the fascial incision will be in a Y shape. Here, the dorsal arch of C1 is removed, thinning the bone laterally using the Midas Rex drill. The exposure extends to expose the spinous process of C2 and the superior portion of the lamina of C2. Here you see drilling of the bone at the foramen magnum. The drill is preferred to other methods to make sure that a wide exposure is obtained at the foramen magnum. Here you see removal of the suboccipital bone. Sometimes you can get some bleeding from the occipital sinus that is easily controlled with gel foam. To reiterate, you need a wide exposure at the foramen magnum because you need to decompress the cerebellar tonsils, and the foramen magnum is at the site of maximal compression. This diagram shows the bone removal, including the superior portion of the lamina of C2. Here we're opening the dura at the level of C1. You can see the translucent membrane at the depths of the incision. That's the arachnoid. Once the dura is open and the arachnoid's in sight, we use a Woodson dental dissector to create a plane between the dura and the arachnoid. Sometimes there are small bleeders in the dura that need to be coagulated. We coagulate these under irrigation. Here's the Woodson dental dissector creating a plane between the arachnoid and the dura. The knife cuts in the groove of the dental dissector. We found that this is a better way to preserve the arachnoid membrane. Here we're approaching the foramen magnum, and just inferior to the foramen magnum, the single incision diverges into 2 incisions in a V type fashion. This avoids the occipital sinus, which can create considerable bleeding. More superior in the suboccipital area, you can open the dura using Metzenbaum scissors. Here you can see the inferior aspect of the cerebellar hemispheres. The spinal dural opening needs to extend inferior to the cerebellar tonsils, and here you can see the cerebellar tonsil on the right extends inferior to the tonsil on the left. Sometimes there are small vessels that bridge from the dura and through the arachnoid. They're coagulated and cut. You can see the exposure extends inferior to the tonsil on the right, and this is a diagram of the exposure. You can see that the arachnoid is intact and the dura is tacked up. The pericranial graft is very pliable. There's no rejection of this autologous graft, and the seal that's made with this autograft is much better than with allograft, and that's why we prefer to use autograft. Even more assurance that the closure is watertight, we use fibrin glue exterior to the dura. Here the fibrin glue is in place, and you can see the pulsations of the brain indicating a watertight closure. Close the fascia tightly. This is the Y-type incision that was described before, and you can see that with the cuffa fascia attaching to the superior occipital line, that the muscles are reattached to the suboccipital bone, and this provides for a nice smooth contour of the muscle and avoids sinking of the muscles that can be seen with the midline fascial incision. The galea is closed above the inion, and the skin is closed with skin staples. This treatment resulted in complete resolution of all the preoperative symptoms in this woman. We have found that the described procedure of extraarachnoidal craniocervical decompression and duroplasty is a safe and effective treatment for Chiari 1 and syringomyelia. We favor this procedure over methods that open the arachnoid because it avoids invasion of the subarachnoid space, avoids neuronal injury, and avoids the creation of adhesions within the subarachnoid space.